Well, welcome everybody. I'm Dr. Kimberly Brown. I'm a transplant hepatologist at Henry Ford Hospital in Detroit, professor of medicine at Wayne State University, and professor of medicine at Michigan State University. And what I'd like to cover today, just briefly, is how to monitor and follow up your patients with hepatitis B. So I think to set the stage, I always have to think about what are our goals, right, with treating hepatitis B. And we have several goals. One is obviously to prevent progressive liver disease onto cirrhosis, giving patients risk of liver cancer, liver failure, needing transplantation. But we also have to consider the risk of transmission to other people. So those are really our goals of treating patients. Now, when you look at the guidelines, and there were just recently new guidelines that were published by the AASLD, when you look at the guidelines, there are certain groups of individuals that we target for treatment and others that we do not. And then now with the new guidelines, there are those in-between patients, those sort of intermediate patients that really didn't fall into the treatment or non-treatment category, where I think we're becoming more liberal in terms of treating them for the reasons that I just outlined. But we do have this group of patients that we have traditionally considered inactive carriers. And for those individuals that are considered stable, I would typically want to continue to monitor them at least twice a year with laboratory testing, including DNA, as well as liver enzymes, as well as a fibrosis assessment. So the laboratories I really do every 6 months, and the fibrosis assessment I do once a year. And what am I looking for? I'm really looking for patients who are progressing and may fall into a treatment category, or patients who have started to replicate or have changed their status in a way that would indicate that treatment was preferred. And then when we talk to patients who do have hepatitis B in our clinic, it is important to remind them about the transmission risk, right? So we talk to patients about their own personal risk, but we also talk to patients about their risk of transmitting to others. So in individuals who do have hepatitis B, it is always recommended that household and sexual contacts be tested and vaccinated if they're not immune. In the household, people should understand that this virus can be transmitted through blood or secretions. And so general counseling includes avoiding things like toothbrushes or razor blades that might contain blood, using condoms to decrease the risk of sexual transmission. At the end of the day, though, general contact with your family, hugging, sharing food items, those are not really routes of transmission. So people should protect themselves with testing and vaccination if appropriate. But again, that is for the household contacts and sexual contacts. And then when a patient is on treatment, again, they continue to require monitoring for a variety of things. One is response to treatment. So if you have a patient on antiviral treatment and your goal is to reduce viral replication, monitoring viral replication, I usually do it every 3 months when a patient starts to make sure that they're responding. But again, once they are on treatment, at least every 6 months, and you're looking for continued suppression. Now, if patients are not virally suppressed, they're probably not taking their medication, because the medications that we have, both tenofovir as well as entecavir, have very good rates of viral suppression. So if patients start to replicate, it generally means they're not taking their medication. So monitoring that is important, but also monitoring for risk of cancer. So inappropriate patients, monitoring every 6 months with imaging such as ultrasound plus alpha-fetoprotein, but also monitoring at least on a yearly basis, in my opinion, with liver enzymes, as well as some kind of fibrosis assessment, fibro test, fibro scan, something to assess their degree of fibrosis to ensure that you're monitoring them appropriately. And then the particular category in terms of counseling that I think you have to remember are young individuals, particularly women who may become pregnant, who have hepatitis B. Now, it is recommended that every pregnant woman be tested for surface antigen, because there is a risk of transmission to the child or infant at the time of birth. If you have a patient who is found to be surface antigen positive, again, it's recommended that depending on the viral level, you may want to consider antiviral therapy starting at week 28 in patients in their third trimester. Again, if they have a viral level greater than 200,000, that would be a patient that you would want to place on treatment to decrease replication and decrease transmission to the child. But always remember that that patient may be a candidate for ongoing treatment in their own right. So they may have just been checked for hepatitis B. But if you find somebody, obviously protecting the infant in the third trimester with viral therapy, however, make sure that you continue therapy if it's appropriate for the mom following delivery. And then finally, in patients who are undergoing chemotherapy, so this is a tricky one. Patients who are undergoing chemotherapy are recommended to be tested for hepatitis B with a surface antigen and a core antibody. Now, not all oncologists do this, and in a patient who is surface antigen positive, who is going to be immunosuppressed, and that can be a bone marrow transplant, it can be chemotherapy, it can be long-term prednisone therapy greater than a month. Those patients who are surface antigen positive need to have prophylactic therapy to decrease the chance that they will start to replicate and have complications moving forward. Now, the core antibody positive patient, and you remember, if they're surface antigen negative but core antibody positive, it means they've been previously exposed. But because hepatitis B really never leaves our body, those patients can start to replicate under immunosuppressive therapy. Current recommendations are that in patients who are core antibody positive alone, if they're receiving rituximab or anti-CD20 therapy, those patients would require prophylaxis. With other medications, other chemotherapeutic agents, they should be monitored, but not necessarily prophylaxed. So those are the things that I do to identify and monitor my patients with hepatitis B. Again, you're looking to try to prevent progressive disease over time. Now, one of the things that I think you'll start to hear about is functional cure. Currently, we don't really cure patients with hepatitis B. We just suppress viral replication. But there's emerging data to suggest that in those patients who become surface antigen negative, that over a period of time, and again, it depends on viral replication, it depends on the e antigen status, that some of those patients may be able to stop therapy. I think those are individual decisions, and I think those are potentially patients who should be referred to a specialist who cares for patients with hepatitis B to make those decisions. So I'll thank you very much for your attention today, and I appreciate your time. Thank you.